these are my disclosures. None of them are related to the talk today. I think we find asymptomatic small stones on imaging all the time. And I think there is a debate about what to do about additional stones when you have a patient that you know you're already taking to a procedure. And the guidelines are mixed. There's not great advice about how to manage these little stones that are in a separate location. And we also know that after our lithotripsy procedures, whichever of the types that we use, there are often residual fragments that are left over. These have been studied very well in lots of studies to look at what happens and what the natural history is of these fragments and pieces that are left over. And we know that some portion of them, especially if the stone fragments that are left over are larger, will eventually cause trouble, either in the form of an ED visit or a hospitalization or requiring an additional surgery down the line. And what's unclear is whether these small upper tract stones are better, worse, or the same in their behavior. You could expect that they may be larger than a cluster of residual fragments. They may be attached, but there may be several of them. I think we've all seen patients where they have a whole bunch of little stones. There's also a couple of studies that pre-existed our study that I'm going to focus on today that have been retrospective and have had mixed results about if you go after these additional stones, whether patients benefit or not. And depending on the way that you look at the studies, the results are sort of mixed. The bottom study there, includes stones that were under 15 millimeters, which I would argue is not a small asymptomatic stone. Those are big stones in my practice. But if you do treat the additional stones, then it reasons that patients would be a little less likely to have something happen down the road. The only prospective study was a study that actually favored observation, but again, they used stones that were less than 15 millimeters, which isn't small. There was a trend towards, if you were stone-free in the treatment group, that you did a little bit better, but there weren't any differences in additional treatments, hospitalizations, UTIs, stent problems, quality of life, or renal function. So the end result is that there's clinical equipoise. I think that if you looked at a large group of urologists, there are some that would treat only an acute stone, for example, in the distal ureter, and they might leave the upper tract stones alone. There are some that would treat the acute stone plus any ipsilateral stones, and there's some surgeons where if you come for a procedure, you get everything cleared out if it can be done in one setting. So this prompted a study that we published in the New England Journal of Medicine about 2 years ago that specifically addressed this question. We worked very hard to try to come up with a definition for how to describe the different groups, because that was really important. And essentially, a primary stone was a stone that you decided was worthy of treatment. And so for most of us, that's an upper tract stone that's 6 or 7 millimeters or bigger. And a secondary stone would be in this example, would be in the contralateral kidney. But you also could have a primary stone that was in the ureter that was prompting a trip for a procedure, and small stones up in the same kidney or in the other kidney. And that would still be considered a secondary stone in a remote or a distant location. So we're not talking about like a big upper pole stone and a small lower pole stone, because I think most of us would treat those at the same setting. All the secondary stones were less than 6 millimeters, and we really were not going after like 1 millimeter tiny little flecks. So it's, on average, these are 3 to 4 millimeter stones. This was a prospective, multicenter, randomized surgical clinical trial. We ended up with 38 patients that went into the treatment group, so they had their primary stone treated. And then at the time of the procedure, we would open an envelope and essentially they would go into either the treatment group or the control group. And in the treatment group, we would go after those secondary stones in the same kidney or the opposite kidney. And the control group, we would treat the primary stone and then be done. We followed these patients for 5 years. They got CTs at about 3 months post-op and then annually. and we followed them for events or relapse afterwards. That was our primary outcome, was relapse, and it was defined in 3 ways. The first was if you had a future emergency department visit, if you required an additional stone surgery, or you had growth that was specific to that side of randomization. So if your randomized side was on the right and you had an event that came from the left, that didn't count. It had to be from the side that we were tracking and following. We also, there was the cost of the additional procedure time to go after these additional stones, so we tracked that as well. And then there was some concern that with the additional instrumentation that you might have more discomfort, you might have more likely to touch an ED within a couple weeks after the procedure. This is our flow diagram. You can see that we had about 75 patients that were randomized. They went pretty close to 50-50 between the 2 groups. Just to point out that this is where we get our 38, where they went into the treatment group, and 35 that went into the control group. We only had 1 patient that was lost to follow-up. A large number of these patients were in the VA system, which they're tracked pretty closely, and they often get the majority or all of their care within the VA system, so that was a big advantage. It was not exclusively in the VA, but a lot of them were. You can see that the demographics look very similar to what you'd expect to see for stone formers. It's around 50% of the stones that is the primary stone is a kidney stone. The other 50% were ureteral stones. They're a mix between left side and right side. These were mostly ureteroscopies, though we did have a few PCNL patients that had a contralateral stone that entered into the study. You can see that most folks had 1 additional asymptomatic stone, but there were some patients that had 2 or 3 additional stones, and they were in the 3 to 4 millimeter size range. If you look at the primary outcomes, the groups are very different. This Kaplan-Meier curve on the left side here shows the relapse rate for the 2 groups, and you can see that in the control group, they have events and relapses that trickle along, with about 63% of them over the 5-year time period having a relapse event. That's very similar to prior studies where we would say that it's about 50% at 5 years. And the treatment group was only 16%. So they had those where we went after the additional stones had a long time before they started having these relapse events. So if you think about the graph in an up-down fashion, the risk of relapse was about 82% lower in the patients where we went after the additional stones. And if you think about it from left to right, the time to relapse was almost double of what it was if you were in the control group. There was some concern that this might be, the relapse, if you remember, was 3 aggregate episodes that could happen. And there was some concern that because we were doing CT on all these patients in follow-up, that stone growth might be driving the relapses. And so as a secondary assessment, we pulled those folks out and looked just at the 70% of the patients that had relapse where it was a hard endpoint, which would be a surgery or an ED visit related to that stone. And the groups still remained very different between the 2. So there was a longer time to relapse. It's also interesting to note that the 6 treatment patients that had relapse all had some residual stones. So even though we had intended to go after additional stones, we were clearing the majority of them, but sometimes not all of them. And those residual stones in the treatment group were the ones that led to trouble. To go after the additional stones added a median of 25 minutes of operative time. And there were no differences between the 2 groups in how frequently they touched the ER for the 2 weeks after the procedure, so it seemed like we were not causing additional harm for the patients. Interestingly, all of the ED visits were due to stent discomfort. And there was also no difference in patients reporting stone passage after the procedure. And between the 2 groups, there was no difference in their stone formation over the follow-up period. Now that is a little tricky because all these patients were approached and were candidates to have medical therapy to evaluate and prevent additional stones. And I will say that the surgeons of us who were a part of this study and recruited the patients are all big believers in medical prevention. So the prevention effort was a strong one across both groups, but no differences between them. So The take-home point is if you have a patient that is already going to the OR to have a primary stone treated and they have additional stones in a remote location, that at the cost of about 25 minutes of additional OR time, there is a significant benefit as far as the risk of relapse down the line. Now, what this doesn't tell us is, do these small stones warrant treatment on their own if you don't have somebody who's going to surgery? That's a study that actually is just being developed now, so we'll have some answers to that. But it is possible, I think, with this frequency of an event rate, that with less invasive technologies, that might be beneficial. There are definitely some limitations. This study was small. There's very few non-white subjects. I think that's the diversity of the groups was not awesome, and that's a manifestation also of a lot of the patients being in the VA practice. The participants in this study, the surgeons, are all endourology experts as well, and so that might influence operative time, the thoroughness of treatment, the ability to actually treat those additional stones. And we were unblinded at the time of treatment. You know, they all got into the study and were candidates for it, and at the time of the procedure was when we found out which group they were going to be in. But the relapse rate is pretty high. I mean, there were 35 patients with 36 relapse events. That's about one relapse event per person, as opposed to, you know, less than 0.2 in the treatment group. And again, these residual stones, even if we made that attempt to treat the additional asymptomatic stones, were still troublesome. This makes me think about the way we used to think about large staghorn stones. These are, you know, a bunch of papers that I distribute to our residents where we talk about, you know, the management of the asymptomatic staghorn stone. And this was in the 70s, where you had patients that were not great candidates for surgery, and at the time the surgery was a very invasive surgery, right? It was not a PCNL. It was, you know, an open nephrolithotomy to clear these stones. And in those studies, which were mostly observational and mostly in patients that were really frail, there was some disagreement about whether we should treat these stones or leave them be. And in the end, they don't end up asymptomatic for long, I think, is the take-home point. And so the needle has certainly moved to where, you know, not necessarily everybody who has a large stone, but our threshold to treat these stones, you know, there's not clinical equipoise about that anymore. And a big part of that is because it's driven by a less invasive technology that sort of came onto the scene. I think that the current treatment threshold that we use to pursue these surgeries is really, we're trying to prevent an unsuccessful stone passage. So I think most of us in this space work towards treatment, and you know, around a 6 or 7 millimeter stone or larger, we start talking about treatment. But we're not moving to treat 2 and 3 millimeter stones, which those would still oftentimes be symptomatic. So we're really not trying to prevent ED visits or painful stone events. We're trying to prevent surgeries that are urgent, where a stone gets stuck, essentially. And I think that's an interesting way to think about it, because as we have additional innovations that come, it may further favor treatment. Thanks for your time.